Thank you for that. Thank you for that kind introduction and the opportunity to discuss a little bit with you how we manage hamstring injuries. I'm quite brave to pick the physiotherapist to talk about platelet-rich plasma injections, or whether we can simply do our rehab. I have no conflict of interest. I'm not affiliated or sponsored by any company that produces or distributes PRP, but I am a physiotherapist, so I'll admit that I might be slightly biased towards exercise prescription. So I won't deny that. So we really have two learning objectives today. The first is, do we have evidence that using PRP is helpful in managing hamstring injuries? Now, it's really popular and well-discussed treatment intervention, and it has a bit of a Shazam effect. Shazam was first described in the comic book era as this wizard who turned an ordinary guy into a superhero. So turning this ordinary thing into a superhero effect. Do we have evidence for this? Or can we simply load our patients? Can we use loading of the tissue to treat these injuries and just use our regular rehab prescription? And do we have a good argument for that? Now, I think science is kind of always catching up. And we're all clinicians, we treat patients, and you often have intuitive feeling about what works. And that often can be correct, and you've seen that with your patients. But I think, like we've heard today, evidence helps us to make good decisions. And when the evidence starts to build, I think it's good to just reflect back on your own clinical practice, and that thing what seems so obvious might not be that obvious anymore. Now with PRP, we have a bit of a halo effect. These celebrity athletes with high-profile sports personalities who get treatment and then testimony of how well it worked for them. And we can't deny that that affects our thinking, and also our athletes that we treat. They have certain expectations when they hear these stories. Most recently, perhaps, Usain Bolt at the Olympics with his hamstring scare just before the competition started and flying to Europe for special treatment. So we have to think about how that influences our reasoning as well. A good way to perhaps counter that effect is to do good research. And here at Aspetar, we've been very lucky with a host of researchers and clinicians that have contributed to both these two questions, do we use PRP and our rehabilitation? The one person I don't have on there is Serene, who was a pivotal part of one of our biggest hamstring projects. So I'm sorry, Serene, I couldn't find a good picture of you. But we're very, very lucky at Aspetar. And in BJSM, now the leading sports medicine journal, there's been quite a number of issues that have dealt with this in particular, looking into whether PRP is a good option and a validated treatment option. In this most recent cover page in 2014, asking this provocative question, is PRP a treatment still looking for a disease? So just quickly, I know most of you will know how PRP works, but just for those of you who don't, this is a really simple explanation. We draw blood from the patient, we spin it really quickly in the centrifuge and separate the components of the blood, and we're really interested in the platelet-rich part of the plasma. Why? Because we think that this part of the platelet-rich plasma has growth factors, so special proteins, that speeds up our healing. So like fibroblast growth factor, for instance. So that's the idea. So if you go and search for PRP treatment, there's commercially quite a few things that it's shown to be useful for. So great skin treatments. You can see that these pictures are exactly the same. There's no close-up or lighting effects or anything like that. This guy's had a really good result. You can get the vampire facelift. Here you'll notice that, well, you can't see it, but here in the corner it says model, not patient, but vampire facelift is an option. So really good results expected with that. Or for hair loss. I hope I don't have too many audience members that needs that. But again, these pictures are exactly the same, no close-ups, no lighting effects, and this guy must be really happy with his hair growth after 60 days. So there's been a number of different things we could use PRP for. In seriousness, it's also been investigated in a lot of the pathologies we see, particularly tendinopathy. There is some evidence now that it might be useful in degenerative knee conditions, but we'll just ask the question, is it useful for hamstring injuries? Now, the definitive work that's been done so far is from Gijs Reerink from the Netherlands, also a former research fellow here at Aspetar. And his PhD looked exactly at this. Can we use PRP in the acute management of hamstrings? There's been 2 other randomized controlled trials together with Gies, and I've borrowed this slide from Adam Weir without his permission. Gies' study, the first one I showed there, compared PRP to a placebo. So that's a double-blind study. I think Vasilis will agree that's level 1 evidence. So neither the treating clinician or the receiving patient knew what they were getting. And when they compared these 2, there was no difference. The PRP and the placebo were the same. Then the Malaysia study from Hamid et al. Showed that they compared PRP to just regular physio. So they added PRP on top of their physio program. And they did find a significant difference. The PRP group did better. But there was no blinding there, and we have to consider that there might be some treatment bias that would have influenced those results. But they found a positive effect. And then the only study in professional footballers was Dr. Bruce Hamilton, also former acting chief of sports medicine here at Aspetar, and he also compared PRP to placebo. That was actually a 3-arm study, but they also found no difference. So the evidence seems convincing. Here's the graph from, let's say, the best of those randomized controlled trials from Gies' trial. And it's really simple. On the y-axis, you'll see the days to return to sport. This is the PRP group, and this is the placebo group. Now, so I don't have to explain that any further. You can see that both groups do exactly the same in their return to sport. So I'll quote Professor Karim Khan. The good news is that PRP is not worse than a placebo. And clinically, we can say it's probably better than cortisone, but for the players who's not smart enough to realize they could just stick with their rehab, and that's probably still their best bet. Now, with PRP, I was a little bit provocative earlier, there are still some unanswered questions. We don't really yet know which growth factors are important, how much of them we need, how does it change over time, when do we put them in, at 2 weeks, 6 weeks, 12 weeks, and why would they stay in the same place? Why wouldn't they just spread out? If they do, in fact, kickstart the whole thing anyway. So these unanswered questions with very limited evidence to show a positive effect remain. So our second learning objective then is, what about loading the tissue? Can we use our simple exercise prescription to treat these injuries? Now, first, we ask, how do muscle respond to load? The answer is mechanotransduction. So that term simply explains how there's a cellular response to a mechanical stimulus. So a biochemical reaction that has physical structural adaptation to the demands of the load, so it's specific to the load, and then you have cellular communication that allows this to be even more effective. So this is mechanotransduction. And we're really using the movement and turning that to turn that into repair. Now, mechanotherapy has been around for quite a while, since the late 19th century. I was a little bit surprised by that. And it's really any form of manipulation of the body, but particularly using exercise. The seminal paper that's been written on this was from Karim Khan and Alex Scott in 2009. And if you do nothing else after this presentation, read this paper if you don't know it. And they really describe mechanotransduction in 3 simple steps. So I'm going to do that now because I think it's valuable to understand this process. And it's really actually quite simple. So we have mechanocoupling, that initial cellular response to the biochemical stimulus. The cells communicate, and then eventually we actually have protein synthesis at a cellular level. So the mechanocoupling is really simple. Here I've just taken a portion of the tissue. This is all in this article, right? So if you find that article, this is all from that article. And presented the extracellular matrix with the tendon cells. So the tendon cells are these right here. So what happens is when the muscle is in a normal steady state, they're usually quite well aligned. And then when there's a shearing force, like we would do with a hamstring eccentric contraction, there's literally deformation of the cell. So there's a physical change due to the load. And that kind of tugs at these cells. And of course, you have different kinds of loads. And the volume, duration, and the type of load will change that. Then, so you have this mechanocoupling effect, a mechanical stimulus that actually tugs physically on the cells. And then there's actual cell-to-cell communication. So we've removed the collagen here to show you the interconnecting cellular network, and they're connected through these gap junctions. So these special regions in the cell that communicate through specially charged particles. The important point here is you can have an effect in one part of this, the tissue, on one of the cells, but the message will spread throughout the tissue. So you have a tissue response to the load, not just on one localized level. Now I've blown that up a little bit more, so now I've gotten rid of more of the collagen. This is the tendon cells even more, and we're going to highlight it, and we're going to look at just one small portion of that. And really explain how mechanical loading now, through the next phase, creates protein synthesis at the cell. So this is the tendon cell, and we've got the cell nucleus here. This is the DNA, the cytoplasm, the membrane, and then that's outside the cell, the extracellular matrix. These integrant proteins sits here on the cell membrane and connects the outside and the inside. They're also attached to the cytoskeleton, so that maintains the integrity of the cell, and that's what responds and distributes the mechanical load. So when we do our exercise, when we apply a load to the tissue, that actually stimulates the integrants to flip, and this triggers the signaling pathway. First, that happens with this physical connection to the through the cytoskeleton to the nucleus, and that already creates the cell to act. The second pathway is through biochemical signaling agents. So there's a complex process of things that happen, but basically these signaling agents move towards the nucleus. They stimulate the nucleus to transform the genes, and they produce mRNA. So that's what's needed for protein production, right? So now the cell produces ribosomes. That creates collagen, ribosomes, that creates proteins that's then extruded as collagen through the matrix. And the collagen, again, is what we need to repair our injured or broken tissue. Right, so incredible that the load that we apply through these three simple steps, mechanocoupling, the cells communicate, and then at a cellular level, they're producing the protein we need to heal. So your exercise you're giving to your patient actually creates the healing. And there are many examples of this. This is from the paper by Jarvinen in ACSM in 2005, a great overview, and it clearly shows how the effect of mechanotransduction has helped the healing tissue here in the mobilized tissue, and the immobilized tissue just hasn't had the same type and kind of healing. Do we have clinical evidence for using loading? Well, we're always doing something, right? It's very rare now that you wouldn't do anything. But I've highlighted this paper by Carl Askling, who used really focused mechanotherapy, so a very specific kind of loading to treat his hamstring patients. And I won't go into the details too much, but basically showed that he could reduce the return to play time. This study is very particular and it has a long rehab time, but you can't deny that that's a pretty great reduction in return to sport. So we can use our focused mechanotherapy to influence the return to sport and to load the tissue more effectively. And then Chris Bleakley for Glasgow has written great pieces on how we can use optimal loading not only in the acute setting, but also integrate that into our rehabilitation. So my take-home messages from this presentation today is there really is no such thing as a free lunch. So if it's too good to be true, it probably is. And we as through our exercise prescription, can use focused mechanotherapy that has a cellular effect, producing the things we need for healing, and that creates greater outcomes for our patients and better return to play times as well. Thank you for your attention, and I hope you all make it to Monaco next year.